She has exceedingly coronally oriented facet joints, which means that her lumbar spine successfully rotates but does not flex and extend very well, which just means we have to adjust her in a more... Wow. What's up, everybody? Dr. Alec here. I'm here with Kaylee. And today we're going to be talking about and treating hip flexor dysfunction. So that is a very broad term that could be divvied up into lots of anatomically specific causes, but today I'm going to be addressing the kind of hip flexor dysfunction that is specific to like a sensitization of the psoas tendon that is secondary to either repetitive overuse from sitting or repetitive overuse from things like running or lifting weights. So this all starts with an exam. So Kaylee, could you get on your back for me, please? So your hip flexor originates on the 12th vertebrae of your thoracic spine, anchors on several other vertebrae, then dives through your pelvis and anchors itself, it inserts itself on your femur. So if you're feeling pain kind of in your groin, right in the crease when you fold your leg, that's essentially right where your hip flexor is. And Kaylee just revealed that you did have...
I did. I don't know what I did, but in college, the right one, I had to take weeks off of field hockey for it.
Can you point exactly to where it hurt?
Here.
Yep. Right there.
Yep.
Yeah. So if it's true hip flexor pain, it's going to be beneath. It's going to be inferior to these bones of your pelvis. If it's above, it's probably more of a like a legit abdominal issue. But that is definitely in the hip flexor region. So to examine a hip flexor dysfunction, there's a couple ways to do it. Someone who has a dysfunctional hip flexor, they're going to have pain when you start closing down. But she has an excellent range of motion, so probably no pain there, right?
No.
You sure?
Yep.
Okay. They're likely going to have awesome external rotation because that's opening up this relationship between the femoral head and the acetabulum. But when you go into internal rotation, so you have out of this world internal rotation.
Still gets it though.
You felt a little pinch in there?
Mm-hmm.
Okay, so most people, frankly, if you push hard enough, you're gonna feel a pinch in your groin if you internally rotate your hip enough. But I would say that yours is well within, maybe exceeds normal limits.
Sick.
Pain there?
Mm-mm.
Pain there?
Mm-mm. Crazy.
Good there?
Yeah.
Okay. Someone with hip flexor dysfunction might also get a little bit of pain with this figure 4 move. You're a little tighter in that. This is not as sensitive though because this kind of motion can be inhibited by some of the more posterior musculature too. Do you feel any pulling in the front of your groin there?
A little bit here, but not like crazy.
Okay. And then just something else you can do. In a perfect world, we do not have the ideal table to be doing this on right now. In a perfect world, we'd be on like a massage table where I could get her to scoot her legs to the crease of the end. Yeah, and sometimes when people's hip flexors are really tight, so something else I need to say, another prime hip flexor is actually, it's your rec fem, it's one of your quads where it anchors up, it crosses the hip joint. So although it's not that iliopsoas muscle that dives through your pelvis, your rec fem can sometimes act as, it does act as a hip flexor. So if you kick a leg off to the side like this and you notice that someone's leg is a little too extended, you might be able to implicate the rec fem in that too. Okay, so here's how I'm going to treat this today based on the fact that she has just kind of, honestly, relatively benign run-of-the-mill hip flexor pain. I'm not going to dry needle her. I'm not going to use shockwave. That's for something more like a psoas tendinopathy. But what I am going to do is some very uncomfortable soft tissue work where the belly of the muscle, belly of the psoas is in her abdomen. And then I'm going to kind of work down into her groin too. So for that, I'm going to need to get some help. Be right back for that. So the way we're going to start a psoas release is we're going to get Kaylee. Have you ever had this done before?
No. Ooh, it's going to be so fun and exciting.
This is going to be a really, this is going to be novel, to say the least. So we start with a nice flexed hip, and then I'm going to essentially come in. I'm going to slide the viscera out of the way. I'm going to weasel my way between the obliques and the rectus abdominis. I know it's not comfy, but I'm going to run. Yeah, she's kind of feeling me get there. There.
Oh my God.
That hard band that I found, that is your psoas. It's all the way up there. So Dr. Jonathan is slowly going to extend the hip while maintaining downward pressure. It's really intense. He's going to push down, so he's going to adduct the hip. Amazing. And you're going to reach over your head with your right arm as far as you can. So that's really gonna just elongate. Wow. Yep. So there's one rep. You okay there?
Yeah.
You sure?
I just need to breathe.
You need to.
Yep.
Okay. So now I kind of know what I'm doing. I'm gonna weasel my way down into a more lower part of that belly. She's gonna feel it in 1 sec. Go for it. There. Reach that arm overhead for me.
I forgot.
Yeah. I know you don't appreciate that all that much. It's a little wild.
That one's freaking crazy.
It's crazy. So for this next one, I'm gonna like grab her ASIS, curl in, and try to pick up a little more of that iliacus, which is a different flavor. Go for it. Give me that big reach. I know that's super special. Amazing. And just for the very last pass of this, I'm gonna come right onto the tendon itself.
That feels funky.
I know it feels funky. Go for it.
How fun.
And then reach. Frankly, this is probably the least intense one of all.
100%.
Amazing.
Wicked.
You okay after all that?
Yeah.
Thank you for your aid, Dr. Jonathan. I appreciate you. So now at this point, now that she's loose and I know that the musculature of her mid-low back and hip is super extensile, I'm going to adjust her.
Oh, word.
And we recently got an MRI of Kaylee's back that probably warrants another video. She has some very funny looking joints in her low back.
Dude, it went so bad already.
It literally already went. Let me get you on the other side though.
Oh well.
She has exceedingly coronally oriented facet joints, which means that her lumbar spine successfully rotates but does not flex and extend very well, which just means we have to adjust her in a more... Wow. I'm not even going to beat that up. Let me get you on your back. Yeah, she's different. And what goes with that is she's also the kind of person who likely doesn't need a lot of spinal manipulation. She does not have a mobility issue. She has a stabilization problem at the end of the day. Nice. Cool.
Fun.
You cool with all that?
Heck yeah.
Okay. So listen, that was fun. So that was a really quick and dirty approach to hip flexor pain. There's many rabbit holes we can go down to determine whether this is labral, is this an osseous abnormality, is it a legit psoas tendinopathy, is it referred pain from your lumbar spine, do we have a nerve caught up in the hip flexor? There's a lot of different possibilities here, but in the case of someone who has really benign hip flexor overactivity, like someone who sits or runs a lot, this is exactly how we would treat it. Thank you so much for watching. Don't forget to subscribe. Bye-bye.